evening. So thanks everybody very much for joining this evening and for being prompt. My name is Alison Scowcroft. I'm Community Pharmacy Clinical Lead for NHS Greater Manchester. And I'm joined by colleagues Sarah and Rachel, who can introduce themselves, and also Kenny, to talk to you about the COVID Medicines Delivery Unit Community Pharmacy Service. So I'll hand over to Sarah and then Rachel for them to introduce themselves, please.
Hi everybody, Sarah Roscoe. I'm Associate Director of Strategic Commissioning at NHS Greater Manchester ICB, and along with Kenny and Alison have been leading the re-provision of the COVID Medicines Delivery Unit for Greater Manchester. So thank you everybody for coming along tonight, and hope you enjoy the session.
Yeah, evening everybody. My name is Rachel Ingram. I have a few hats. So I work for Mastercall Healthcare, which is an out-of-hours provider in Stockport, but I also work for Greater Manchester Urgent Primary Care Alliance, which provides the Greater Manchester Clinical Assessment Service, or the CAS as it would be known, and we're going to be doing the CMDU service for GM. I also work clinically as an advanced practitioner, so nice to meet you all. Thank you.
Thanks, Rachel. And Kenny?
Yeah, hi, I'm Kenny. I'm Chief Pharmacist for NHS GM. Really pleased that we're making great progress on CMDU. This is a really important area, so thank you for your support with this.
Thanks, guys. So welcome to the webinar this evening. Hopefully we won't keep you too long. We've got some slides to go through, and then there'll be plenty of time for questions and answers at the end. If I could just request that everybody who's joined the call, could you just pop your name and the pharmacy that you're from in the chat? That would be really helpful, please. And then we know who's joined and where everybody's up to. That would be great. So I'm going to I'll go give you a quick overview of the agenda. So Sarah's going to give us some background and context to the CMDU service. I'll give you an overview of the service and some detail around the training that's in the service specification. I'll hand over to Rachel, who talked to you about what's happening at the UEC end of this service, and then hand back to me, and I'll go through a demo of farm outcomes for you. So, and then, as I said, time for questions and answers at the end. So I'm going to hand over now to Sarah just to give you a little bit of background and context. Thanks, Sarah.
Thank you, Alison. So hopefully everybody's aware of the COVID Medicines Delivery Unit that was previously delivered at MFT, which was a single site service. This was set up at pace in response to kind of the national directive that was coming from the centre around the provision of antivirals to vulnerable eligible patients that contracted COVID. So I think hopefully as a community pharmacy you have been on the receiving end in terms of referrers into this service and receive kind of communication. But yeah, this is kind of the COVID-19 response for, like I say, provision of antivirals, both oral and IV in the CMDU for those patients that are deemed at risk, and as defined by the NICE technology appraisal that was published. So as we said, in 2021, the CMDU service was provided by MFT and has been up to April this year, where they had served notice, and that was by mutual agreement. So myself and Kenny and others have been working closely with the clinical lead and his team in terms of the development of the GM clinical pathway and looking at what a new service model could look like for GM, recognising that an acute service, single site, probably wasn't accessible, and actually kind of the direction of travel kind of nationally is looking at a more community-led service. So in September 2022, ICBs were issued additional directive and guidance around, like I say, reviewing their service model, looking at the people at highest risk as defined by NICE, and looking at a more sustainable service that basically from ICBs to mainstream it, if you like, going forward. Kenny and I, with Lovejit and others, have undertaken significant engagement, both from a primary care perspective, both with general practice and with community pharmacy GM, in terms of what this model could look like. And we absolutely accept that this is not core community pharmacy, it is not core general practice. This is a specialist service that needed to be commissioned. But However, we do recognise the role of primary care in this service. So again, working with the Primary Care Urgent Care Alliance, where we have got kind of looking at a primary care led service, but on a pan-GM footprint, and with community pharmacy across each of our 10 localities, looking at what a new service model could look like. So we fast forward, I suppose, to March this year, and unfortunately, we did have a gap in provision. We know that's caused some issues across the patch, and Kenny and I and others have been working to try and get temporary arrangements in place. But we are pleased to say now, in terms of working with Rachel and colleagues, that the CMDU that delivered by the GM Primary Care Urgent Care Alliance will go live next week. I think with yourselves in terms of, you know, ensuring that we've got community pharmacy provision in each of our 10 localities, delivering the service in accordance with the GM pathway, which is aligned to the NICE technology appraisal. We're looking at kind of, like I say, kind of a GM service that we have got local access across each of the 10. And this is, I suppose, just to qualify, whilst this service will provide oral antivirals and the provision of IV where it's needed, obviously what we're looking at with community pharmacy is just the supply, the stock, and the monitoring around the oral element. So yes, so like I say, what we'd agreed through our governance was to have a single pan-GM provider and working alongside community pharmacy for dispensing and ensuring kind of accessibility in each of our localities for patients. Is there anything else you want me to add, or Kenny or Alison, in terms of that, of where we're up to?
No, I think that's great. Thanks, Sarah.
So if we just look at what the new service model is, and the CMDU service clinically triages, assesses and prescribes COVID-19 antivirals to a nationally defined at-risk cohort. So there was and we will come on to the eligibility criteria shortly. So there is the historic eligibility criteria as published by the NICE TA. However, that has since been amended and updated in March this year. So there has been an expansion. So we will come on to the eligibility cohorts, but that does I suppose it increased the potential cohort significantly. So not for just those patients that have got severe respiratory, suppressed and so on, but now this is kind of age, comorbidities. So it does kind of expand kind of the potential eligibility cohort quite significantly. As we've discussed kind of on point eight, we have identified the UEC Alliance. They are well established, already provide clinical services on a GM footprint through the clinical assessment service and other services that obviously within the respective organisations that they provide. We needed to mobilise quickly, recognising the gap that we had in service provision, and also in terms of specifying a service model, we don't know what the impact is going to be through the expansion of the eligibility criteria. So it's important that we work collaboratively both with the UEC Alliance and our community pharmacy colleagues to monitor this carefully in terms of both activity demand and any surges in demand. We know right now we have got some outbreaks and what is being referred to as summer COVID. Activity is nowhere near as high as it was at the height of the pandemic and when this service was originally set up. But nevertheless, we need to make sure that we have got a sustainable services that has got the ability to flex capacity in the event of surge, which obviously the UEC Alliance with its extensive workforce has and can do. We've mentioned the gap in service provision between the MFT service ceasing and now. We did step up temporary bridging arrangements, but that isn't sustainable. It definitely doesn't give us a consistent message to send to our patients or referrers in terms of what to do. So again, we have been working at pace, and you'll have felt that in terms of the expression of interest and kind of some of the comms that have come through to really get this service up and running for as soon as possible and as early on as in July as we can. We've initially commissioned this for 12 months, commencing now, and looking at, like I say, monitoring the service model, the activity, and what a service could look like on a current basis from 25-26. And that includes obviously securing recurrent funding. What I didn't mention at the start is at the outset, this service was originally funded through COVID monies that came down nationally. But in that correspondence that came in September 2022, there is the expectation that this is now the responsibility of ICBs and they must fund and commission it going forward. So that was, sorry, I should have mentioned that at the start. Thanks, Alison. So the purpose of the community pharmacy service, and again, we absolutely recognise that this is above and beyond core. So to provide those COVID-19 therapeutics for non-hospitalised adult patients, this is an adult-only pathway. Obviously, that compliance with the NICE technology appraisals that are listed there, and what we, the upshot of this and what the evidence presents is we want to reduce avoidable hospital admissions by treating patients timely in a timely way in the community and ensuring that accessibility to COVID antivirals for those that are eligible and where it's warranted. And yeah, it goes without saying, reducing that risk of vulnerable COVID positive patients attending A&E to access treatment for COVID-19. And something that has come down, something that we are mindful of across GM, and something that we're being kind of challenged on nationally as well, is that reducing inequalities and that ensuring accessibility. And obviously, as good as the MFT service was, it was still a single site service that could only dispense from the MRI. So, for patients that weren't in the Manchester locality, you can imagine kind of how problematic that was. So again, with the model that we've developed, ensuring kind of provision in each of our 10 localities, we're hoping, like I say, that reduces inequalities and increases that accessibility. Thanks, Alison.
Brilliant. Thanks, Sarah. So I'll just take over now and go into a little bit more detail of the service itself. So in terms of the aims, one of the key aims clearly is for our pharmacists to maintain an agreed stock of medicines. So we want this stock to be kind of ring fenced and have it ready for when you do receive a prescription. So the majority of prescriptions that you receive will be for Paxlovid. So we're requiring that you maintain stock of 6 packs of 30 tablets. The service spec does also include molnupiravir. We're just waiting for further guidance from NHS England around the role and when molnupiravir should be prescribed. So if you haven't already ordered stock of that, then please don't need to do that just yet. We will confirm that to you shortly. If you have ordered it, don't worry too much about it. It will be included as part of the service specification, clearly. We are also aiming to ensure that patients have access to these medicines both during normal working hours, but also at evenings and weekends. And that was part of the reason, your accessibility, why the 12 pharmacies that we've commissioned were selected, because of the extended hours that you cover. We are looking to provide support via rota to cover bank holidays, but that's not quite yet been defined. So we will be back in touch with you in due course once we've defined what that's going to look like. We'd appreciate prompt dispensing of prescriptions, so ideally within an hour of receiving them, so we can make sure that we fit within that window. That's really important for a patient to initiate their treatment. We'll expect you to complete clinical checks to ensure that the prescribing for these patients has been appropriate. And also as part of your standard core contract, supporting patients and carers by providing up-to-date information and advice around the products that you are dispensing. Sorry, there's a typo there. It says career, it should be carer. Got carried away on that one. In terms of your eligible patients, then the expanded criteria is patients aged 85 and over, people with end-stage heart failure who have a long-term ventricular assistance device, people on the organ transplant waiting list, people aged 70 years and over who have a BMI of over 35, diabetes or heart failure, and are resident in a care home or who are already hospitalised. Clearly, those people must also have tested positive for COVID-19. There's a future expansion of the eligible cohort due next year, which expands this out to people who are aged 70 and above, people with a BMI of over 35, and people with diabetes or heart failure. So the scope is expanding over the next 12 months in terms of the patients who are eligible for treatment with COVID-19 medicines. In terms of the standard patients who are eligible, not including the expansion that I've just mentioned, then the following groups of patients, if they test positive for COVID-19, must have access to treatment. So people with Down syndrome and other genetic disorders, solid cancer, haematological diseases, renal disease, liver disease, solid organ transplant recipients, people with immune-mediated inflammatory disorders, which are listed there, people with severe respiratory conditions, immune deficiencies, HIV and AIDS, and neurological disorders. So there is more information there at the NICE guidance that's linked at the bottom of the slide, and we will share a copy of the slides afterwards, and then you've got them for reference. In terms of training, there's a little bit of prep that we'd like you to do to ensure that you are comfortable and confident with doing the clinical checks that are associated with dispensing prescriptions for Paxlovid and Molnupiravir. So first of all, we want everybody to watch this webinar or watch a recorded version afterwards. It's really important that you familiarise yourself with those NICE documents. So the NICE Technology Appraisal 878 and NICE Guideline NG 191. So really spend some time going through those documents and make sure that you're familiar with the information that's included in there. Also familiarise yourselves with the SPCs for the two products that you're going to be providing. Obviously, that's going to be really important when you're counselling patients or their carers on the use of these medicines. And then the final bit that's really important is using the Liverpool COVID-19 drug interaction checker, which is linked on the slide here. So you will be expected to use that as part of the dispensing process to make sure that the prescription that's being generated by Rachel and her colleagues at the UEC Alliance is clinically appropriate for those patients. There are other resources available on the eLearning for Health website. I haven't tagged them in there because if you search for COVID-19 on the eLearning for Health website, there's a whole raft of stuff on there. But if you felt that you wanted to do any more kind of CPD or any more background, then there are some good resources there that are optional for you to use if you wanted to plug any gaps that you'd identified. So those things are required for the pharmacists who will be dispensing prescriptions within your pharmacies for the COVID medicines. So I'm going to hand over to Rachel now, who's going to talk you through what happens at the UEC end of the process. Thanks, Rachel.
Yeah, no, thanks, Alison. Yeah, so from our perspective, as Sarah alluded to, the GMUPCA or Urgent Primary Care Alliance runs the CAS. So we've already, and we also are the out of hours providers in all the areas across GM. So we have some interoperability anyway to be able to book into other onward referrals as well. So I'm sure you're already familiar with us sending EPS prescriptions already. But what happens is the patient, well, the referrer will complete a pro forma which goes through the eligibility criteria. So this isn't appropriate for every person with COVID symptoms. These are people that, as Sarah alluded to, have got the eligibility. They have to have a confirmed LFT. When they come through, then they will go on to our Adastra system. So we get an email, our core handlers put the case onto the Adastra system. Then it will be a GP-led service. So we will have a GP who's been trained in the antiviral prescribing and all the COVID stuff very kindly from the MFT team that did the training for us. They will go through a remote assessment with that person and ensure that they are eligible and it's appropriate for us. If we feel that they need those antiviral or oral treatments, what they will do is complete that pro forma on Adastra. They will do an EPS prescription to one of your designated pharmacies, the nearest one to that patient. And then as part of that, all the information will come through to you. So you will get a email with all the, as a post-event message that will come through to you with all the questions. So you will see that we've asked all those questions that you will have. So your role will be able to just double check and cross check due diligence for that. The EPS will be sent as normal for the prescriptions, and we're going to allow them for 24 hours. If they don't pick up that prescription, you then can contact the CMDU service for us to then arrange what we call a failed contact. So we will make the provisions to contact that person to see why they haven't picked up that prescription. So that's kind of it in a nutshell. We can also do video consultations with these people if needed. We can also refer people if we feel that they need a face-to-face. We can refer them into sort of their own GP, the GP out of hours, to SDECs, to urgent treatment centres, to urgent care response teams if needed. But the majority of people we feel will be able to manage remotely going through the process. And as Sarah alluded to, we also think that a lot of patients may not require the antivirals, but might need that support. So if they do need support where we think we'll do a watch and wait, those patients will get a follow-up call either 24, 48 hours from us, and we will follow those people up for up to 5 days of them having that treatment if they need to, or follow them up if we feel that they need that for symptoms. So I don't know if there's any questions that people have got to ask. I was going to say, is it worth just saying as well that our GPs will be there Monday to Friday, they'll be there 9 till 6. And Saturday and Sundays they'll be doing operating between 10 and 2, but we will accept referrals from one-on-one, from GPs, from out of hours, from though any sort of healthcare professionals that feels that they've done that pro forma and they filled the referral in, and we can receive those 24/7. It's just that we will then do the clinical assessments between those times. So there is a 7-day offer as well that we will be providing.
Fantastic. Thanks, Rachel.
No, it's all right.
Okay. So Rachel mentioned a post-event message that's sent to you from the Adastra system. So we've got an example here of what it might look like. You're going to receive this by email, so it will be sent to your NHS shared mailbox email address. We've provided those email addresses to Rachel and her team. So that will be sent through directly to your NHS shared mailbox. So there will be an element of transposing data here. I'm afraid we've not quite been able to get the systems linked up enough to be able to talk to each other. So you'll receive a PDF attached to an email, which you'll then need to open up and save or print or whatever your process will be, and then transpose that information from the message that you've received from Rachel and her team into Farm Outcomes. So there'll be patient demographic data clearly that you'll need, and also the patient's contact details. You'll need to make sure you make a note of those, because you'll need to phone the patient or their representative to confirm their collection or delivery arrangements for collecting the medication. So this is just a screenshot of what that sample looks like. Clearly this is a test, so it's got lots of gobbledygook letters in there, but all the questions that are in your Farm Outcomes module that I'm going to show you in a minute have been covered with the questions that Rachel and her team will include in the post-event message that you'll receive. So that's what that looks like. There'll also be contact details for the UEC lines for Rachel and her team. So if you do have any queries that you need to contact the prescriber about, then you will have those contact details included. So that might be if you've got a clinical query around the suitability of the prescription for that particular patient, or as Rachel said, in that case where perhaps the patient or their representative failed to collect the medicines from the pharmacy within 24 hours. It's really important that we close that loop and make sure that that confirmation is sent back through to the team. So I'm going to do a quick demo of Farm Outcomes for you now. You'll have to bear with me because I'm sure everybody is aware that we have multi-factor authentication in place, and it might take me a minute just to log in and get to the right page. So let's hope it doesn't take too long. Got my phone ready. And it's just changing number, so bear with me. It's on a go slow, clearly. Okay, where are we? Don't worry too much about all these that you can see on here. This is just all the different modules that I've got visibility of. So we're looking at these two modules here. So the first one will be a patient registration module. So you will just copy the information over from the notification that you've received from the prescriber, patient's details, who their GP practice is. So you should just be able to type something in and select it. And then you go into confirming the patient's eligibility for treatment. So all the information that is on the post-event message that you've received from the prescriber will help you to answer these questions. So you need to confirm that they've had a positive test, that they are symptomatic with COVID, that their symptoms have been in place for a maximum of 5 days, and that the patient falls into a high-risk group. It will not let you continue unless you tick all of those boxes. So you need to cross-check all of that information over with the notification that you've received. As Sarah mentioned earlier, the service is only open to patients who are aged 18 and above. So you need to click no there. If you put yes, there'll be a warning saying that you can't continue. Likewise, if the patient is pregnant, then you will not be able to continue. So that needs to be no. The symptoms for more than 5 days, you can't treat. So that again needs to be no. And if there's an issue with the patient swallowing tablets or capsules, then again, that's going to be a problem. So that one needs to be no too, so that you can continue. You're then going to record if there's any drug allergies or sensitivities. If you tick yes here, then there's a free type box that will open up for you to add that in. I would suggest that if you have access to the GM Care record, it might be helpful to verify that. I know that's something that we're working on for community pharmacists who are involved in a different programme. So I'll discuss with Sarah how we can accelerate that for the 12 CMDU pharmacies. I know there's a little bit of crossover with the IP Pathfinder programme, but for those of you who are not involved in that, we'll look to add you into the list to get you access to GM Care record as well, so that can help with the consultation. There's then some questions around kidney function, which again should all be within the notification that you've received from the prescriber. If you haven't got estimated GFR, then you can leave that field blank. Then it goes into some discussion around Paxlovid, so looking particularly at the contraindications. So if the patient has CKD stage 4 or 5, then unfortunately that is a contraindication for Paxlovid, so you would need to put no. And then the same with decompensated cirrhosis, again that would need to be no. If the patient takes any other medications, then you press yes there, a box will open up for you to list the medications that are taken by the patient. And here's the link to the Liverpool COVID-19 interactions checker. So you would need to access that link. Fingers crossed the link works. It should do. Yep, so that's taken us straight through to that tool, which is great. So you can use that link to identify if there are any clinically significant drug interactions. And if there are, obviously the box opens up for you to record what those are. I think in that case, probably that would be a conversation with the prescriber to discuss and agree whether it's appropriate to continue. You're then going to record the medication that has been prescribed for the patient. So standard dose, Paxlovid, 3 tablets twice a day for 5 days. There is a reduced dose option, and then obviously we've got molnupiravir. There's a field for you to add any additional information, any notes that you'd like to add around the consultation that's taken place with the patient. Please don't add any patient identifiable data into this field, but please do use it to record any additional information that's relevant. And then we want you to record the details of the prescriber, and then that can be matched up with the EPS prescription that you will receive. And then you should be able to save the provision, and that's it. So hopefully it's quite a simple farm outcomes module. I know everybody's used to using farm outcomes. Hopefully this one has been tried and tested in another area, so hopefully it will work well. We are able to kind of make tweaks and amends to this. If you find that there's a particular aspect of the farm outcomes module that's not working for you, then please do let us know. It's something that we've put together locally, so we can make tweaks. And if there's any other resources that you think would be useful that we can add in there, then we can certainly do that too. So I'll go back to the slides. Slideshow. Okay. So I just thought it might be useful to give you some kind of top tips. So pulling out the important parts of the service specification, really. Clearly all parts of the service specification are important, but just to pull out some of the top tips. So it would be really helpful if you could segregate your stock. So the stock that you're holding, particularly for this service, the 6 packs of the Paxlovid, have them in a basket to one side, clearly marked as stock that you're holding for this CMDU service. And it would be useful if you can keep a check on that stock on a weekly basis. It might be helpful to appoint a champion or somebody in your team who could take responsibility for doing that stock check. With regards to your NHS shared mailbox, obviously it's part of your core contractual requirement that people can access that mailbox. So you must have at least 2 members of staff who can access that at all times. And you should be checking that mailbox regularly throughout the day for any emails that you receive pertinent to this service. As I mentioned before, we ask that you aim to dispense those prescriptions that you do receive promptly, ideally within 1 hour of receipt. You will need to contact the patient or the patient's representative to confirm the arrangements of them accessing that medicine. So who's going to collect the medicines? If it is a patient themselves that's going to collect the medicine, then you should ask them to wait outside the pharmacy rather than coming into the pharmacy. If a delivery is required, then there is provision in the service specification for you to be reimbursed for that delivery. And we've got the details in the service specification around the reimbursement for that. But we anticipate the majority should be collected, but we will monitor collections versus delivery. Don't forget, if you do make a delivery, to claim for that on farm outcomes so that you will get reimbursed appropriately. And please do notify the prescriber if those medicines have not been collected within that 24-hour period. That's really important so that we can close the loop. And Rachel and her team can follow up with those patients and find out what's gone on. So I did mention earlier that bank holiday cover is going to be something that will be required as part of this service specification. We're not quite there yet with the details of what this is going to look like because of the pace at which we've tried to mobilise this service. We're still working on this one in the background with the LPC. So we did ask in the expression of interest form if pharmacies were prepared to take part in a bank holiday rota, and the majority of you did say that you would be happy to support that. So once we've got our ideas firmed up as to how this is going to work, we will contact those pharmacies who did confirm in the EOI that they would be willing to participate in a rota. And what we'll do is we'll outline that in an appendix that we'll add into the service specification just for those pharmacies who are participating in the bank holiday arrangements. So you'll have to bear with us a couple of weeks on that one whilst we just finalise the arrangements of what that's going to look like. In terms of funding, there will be a setup fee paid of £420 that will be paid with the first invoice, and that's to recognise the time that you'll have to spend setting up your pharmacies with this service, the bits of training that we've mentioned earlier on, ordering that stock in, and other setup arrangements that you might have, including thinking about SOPs and such for providing this service. You'll then receive £18 per consultation and dispensing. So each time you receive a prescription for a COVID medicine, you'll receive a fee of £18, which covers the clinical checks and the counselling that you will give to the patient or the patient's representative when the medicine's dispensed. An annual retainer will be payable from the second year of service of £240 per year. And then, as I mentioned, the bank holiday arrangements are still to be defined, but there will be an on-call fee and a call-out fee, and the delivery fee will be slightly different, acknowledging that trying to make deliveries on a bank holiday will the chances are it'll be a little bit more expensive than on a routine day. So some of that stuff is still to be defined. Okay, so that was the end of the content that we had for you today on the slides. So I'll stop sharing my screen and open it up to any questions that anybody might have. Please feel free to come on the camera and talk to us if you want to do that, or if you'd prefer to put your questions in the chat box, then obviously that's okay too. So I think we've got, go ahead, Sham.
Yeah, sorry, can you hear me? I'm not sure. Yeah,
we can hear you fine, thank you.
right. I'm just trying to sort of work this out in my mind in terms of how this is going to work. So you have an EPS prescription that's sent by the CMDU team, but at the same time you have the post-event message which is sent to your shared mailbox. Do they come, can we expect them to come around the same time, or does one come first and the other? Yeah.
Yeah, no, it should be around the same time. The EPS will go once we've, well, the EPS might go first, but not by many minutes. But the post-event message will, at the moment we close that case, it then should come straight through to you as an email. Okay,
so we get the EPS, I guess we'll probably see the EPS prescription come first from a pharmacy perspective. And then what we need to do is we need to sort of kind of reference that with an NHS shared mailbox message that's come from you. In terms of sort of kind of then carrying out those clinical checks with the patient and the completion of the farm outcomes that Alison's just showed us, we would obviously need to have contact with the patient. And if the patient's got COVID and we're saying, don't come into the pharmacy, how do you suggest we do that? Do we do that sort of remotely over the phone, or I'm just trying to sort of work it out in my mind as to how it would work.
Yeah, so I think the best option would be when you receive the prescription and the post-event message. The post-event message will have the contact details of the patient. So I would be ringing the patient and saying, "Oh, we've received your prescription now for your Paxlovid. Can I just check the arrangements? Is somebody able to come and collect this medicine? It'll be ready for you, at 2 o'clock or whatever." And then hopefully someone will be able to come and collect that medicine. I would be asking the question, is it the patient themselves who's collecting, or is it somebody else? And as I said before, if it's the patient themselves, a little bit difficult if it's absolutely tipping it down, but ask them to wait outside the pharmacy so that you don't want them to come into the premises, do you, if they've tested positive for COVID. And if there is a delivery required, then obviously you would make the arrangements with the patient as you're on the phone at that point to arrange the delivery.
Okay.
Rachel, I don't know, would it be included in the post-event message if it was or would you do a consultation with the patient's representative, or would it always be the patient themselves that you would speak to?
No, ideally we always want to speak to the patient, because that's obviously good practice for in any sort of treatment options. But where the patient then has asked, actually, can we speak to somebody on their behalf, we will do. And we normally record that in the post-event message. We would record that in a consultation of who we've spoken to, whether it's the patient or somebody else on their behalf. And also, if the patient, for example, is in a care home and is unable to answer those questions, then it would say who that person was that was giving us that information, whether it was the carer at the nurse at the care home or whatever. So we would include that in that consultation notes that you would have access to as well.
Okay, so what I'm trying to clarify is that at the point of or prior to dispensing that prescription, we need to have a conversation with the patient or the patient's carer, whoever's the most person, and complete that farm outcomes form. Is that it? Have I got this right?
Yeah.
Yeah. Okay.
I'm just thinking, would it be a good option then? I'm just thinking aloud now, so excuse me. Just thinking, if you're contacting the patient anyway to tell them that you've received the information from the CMDU service, is it at that point that you would potentially fill in that form and cross-check the information?
Yeah.
And at least then you know whether you're going to be issuing that prescription, or whether there's a query that you need to then say to the patient, unfortunately, I've got a couple of queries, I want to pick that back up with the prescriber. And there you're not left with a patient or a relative at your pharmacy while there's a discrepancy or a query that you've got. It's just a thought.
So invariably, that would be done sort of on the phone before the patient or their carers in the pharmacy. I mean, the carer could come into the pharmacy, but you would need to have that conversation with the patient
prior to that.
Yeah, prior to that, and then if appropriate, you dispense that prescription and make arrangements for delivery if necessary. Okay, no, that's great. Thank you. I just wanted to really clarify sort of how that would work.
Thanks, Jan. I think it's really helpful questions, thinking practically about how you're going to offer the service in your pharmacy. There's a couple of questions in the chat that it might be useful for us to address. So Mohammed R has asked, how are we required to obtain or access a list of patients' medication to check interactions? So you should be able to access the patient summary care record routinely, which will help with that requirement. But we will also work with you to gain access for the GM care record, which is it gives you a much broader view of the patient's record within the GP's clinical system, so EMIS or TPP system 1. That's a process that's kind of happening in the background, and we're not quite there yet. It's not quite live, but it will be in the next month or so. So there may be a slight delay with that GM care record access, but we will be in touch with you to facilitate that. Alternatively, you should be able to access the summary care record as you would through any other routine process. Rachel?
Yeah, just to say, obviously, as part of our assessment, we would be accessing the Greater Manchester Care Record via GP Connect or via EMIS. So we would that information should be in there for you to then just double check the information that you're getting.
Brilliant. Thanks, Rachel. That's really helpful. Another question we've got, does the patient have to pay for these prescriptions like a normal NHS prescription? I'm assuming the answer is yes. If a patient pays for their prescriptions routinely, then they would pay for prescriptions that they receive for these medicines. Looking at the eligibility criteria, I think a lot would be covered by age exemption or medical exemption, but maybe some of the respiratory conditions perhaps wouldn't be. So yeah, if they do routinely pay for the prescription, I would expect them to pay for this. Would you agree, Sarah and Kenny?
Yeah.
Brilliant, thank you. Has anybody else got any other questions? Sham, you have still got your hand up, have you? Did you have some more questions, or was that your legacy hand?
Yeah, sorry, I think that was just by mistake, but I have got another question.
Go for it.
Incidentally, I mean, in terms of sort of uptake of this, what can we expect? I mean, how many patients, or is it very difficult to say? Just so that we're sort of kind of ready and prepped for any sort of workload or what have you.
Go ahead, Sarah. I know you've got a little bit of insight, haven't you?
Yeah, so we have seen activity reduce significantly, even with these outbreaks that are happening now. So the CMDU, so through the Primary Urgent Care Alliance, is committed. We're putting kind of to receive 15 referrals a day, kind of Monday to Friday, and obviously reduce capacity over the weekend when we know activity drops. Of those 15, we do not anticipate that everybody will be prescribed. I think from the Manchester Foundation Trust Service, we were seeing on average an 8% conversion rate from referral to treatment. So, and on average, I think the CMDU was kind of it's in its kind of single figures referrals per day. We've just kind of recognised that the increase in the eligibility criteria and obviously a new provider, that we are expecting activity to increase. So we're not expecting a significant footfall at all. And what we've been doing with the UEC Alliance and as part of the referral information is just trying to manage demand. So absolutely making sure that those checks at point of referral are absolutely kind of ticked. So patients do fall within the eligibility criteria. That they have got a positive LFT test. They are symptomatic, and we've also got quite, we've made the exclusion criteria quite clear right at the outset. So again, trying to kind of just make sure the right patients are coming through the service, but nevertheless, we have seen that activity is, has dropped significantly. But it's a watch. We're monitoring it as well because, like I say, with the expansion, we don't quite know kind of what the impact will be, but obviously we'll work with our providers closely to monitor that.
Right, thank you.
Rachel?
Yeah, I was just going to add, obviously they'll have already gone through a referral process to see about eligibility. Then they come to the CMDU, who then goes through that eligibility. Before then, you'll be the third one to sort of to assess that. So hopefully there's going to be a lot of scrutiny to check that people are appropriately being prescribed antivirals if need be. And as Sarah alluded to, from what we've heard from recently, is people have been managing.
Oh, Rachel, I think you've just gone on mute there.
Sorry.
Through.
Yeah. Sorry, where did I get to? So I was going to say that MFT, I think, have from the evidence that they've provided recently has been that most people have been managed with sort of over-the-counter remedies and supportive measures and not required treatment. And we've not seen the hospitalisation numbers either that into this for those conversions into hospitalisation. So I think at the moment, again, that's some sort of reassurance that the strain that we're seeing at the moment is something that is being managed. However, it is a watch and wait, and we're there prepared, ready for, taking those cases, and we can review it, can't we, if they're getting more than 15 cases a day. But we don't anticipate that, especially not in the next foreseeable months anyway. Might be a different one in winter, but we can manage that, I'm sure.
Brilliant, thanks, Rachel. Does anybody else have any other questions? Please don't feel that what you have is a stupid question, because this is new to all of us. So no question's a stupid question. We're all learning together.
The only other query I was going to have was if, for instance, an EPS has failed, what we were going to propose was that we would do an FP10 prescription, scan it and email it to the pharmacies, and then send the pharmacist the original FP10 via, send it out via post. Is that's worst case scenario? If for any reason EPS, I'm just considering all options in all of these things, is that something that everybody is happy to agree to? That and we'd obviously contact the practice, the pharmacy anyway, if there was a problem with sending the EPS, but it's just seeing, is that an agreeable procedure to have as a workaround in case EPS failure?
Certainly seems reasonable from my perspective, Rachel. Thank you. I think the only challenge with that is in the regs, there is a requirement that the hard copy prescriptions received within 72 hours. So it would just need to be kind of posted promptly and first class
yes,
stamp.
it will. Yeah, we do. We have first class stamps ready at this, but it's always, I always like to think of all the what ifs. So it's just a what if, on the rare occasions that it might happen, that if everybody's happy with that process.
Yeah, that's great. Thank you. Does anybody else have any other questions or comments? Go for it, Sarah.
Mine wasn't a question. I think it was just that commitment. This is a new service, and I think we, as you said, Alison, kind of we are learning together, and we think we're going to work kind of in terms of with all providers just to get continual feedback, really, in terms of what's working, anything that could be improved, or things that we've not thought of. But we have looked, like I said, I know we have done research elsewhere. We're not the only primary care led model. We know this works in other areas, but as we said, it will be iterative, won't it? So, and I think because we are working with the one provider, with nominated community pharmacists, then we can collectively work together to get that ongoing feedback, and and look to kind of changes needed, really, is in response. But yeah, it was just that kind of assurance, really, or reassurance.
Brilliant, thanks, Sarah. I guess the only other bit that we are still working on in the background that we probably haven't mentioned is around the contracting arrangements. So you'll have seen the draft of the service specification. Sarah and colleagues are working with colleagues in contracting just to finalise what that's going to look like. We do really appreciate your support with this service and your support with mobilising and going live quite quickly. Clearly, Rachel and her team are starting to to see patients from next week, so there is a chance that prescriptions will be generated and sent to one of your pharmacies next week. So recognise that there's a little bit of a period whereby you won't have contracts in place, but we are really appreciative of you guys kind of stepping up and supporting us in the interim and mobilising quickly. We will be contactable if you have any questions or queries, particularly in the early days. So please do feel free to get in touch with us. I think you've got my email address, certainly. So yeah, if there are any issues, then please don't hesitate to contact us. And as Sarah said, we're really open to that feedback. We want to make sure this service works for our patients primarily, but also for the prescribing team and for community pharmacies. So please do keep in touch with us. Go ahead, Shan.
Sorry, just final couple of things, and then I'll shut up. I promise. Just two things that just occurred to me. One is farm outcomes. Will we get this module automatically added, or do we need to contact farm outcomes ourselves? You know, in terms of the.
Yeah, we'll do that for you. So once we work with CHL, who've created the modules, we'll make those live and we'll accredit you in there so that you'll be able to see that and you can have a quick look through before you see any patients. I think that would be helpful. So We'll do that in the next few days.
Okay. And the second point, just for those patients that may need delivery, you're saying that we need to, in an ideal world, sort of obviously turn this around within an hour. That could be quite an undertaking if we're required to deliver as well, to do that within an hour, to deliver medication within an hour, because for a lot of us, I'm not sure about other pharmacies, but you'll have your drivers and they might well be out, you know, doing deliveries. So what's the kind of expectation in terms of sort of deliveries if we have to make them? I appreciate it'll be few and far between, but where that situation arises, what's the expectation in terms of the service spec?
That's a really good question, Sham, and I don't think we've outlined it in any detail in the service spec around that time requirement, particularly because we know it might be challenging. I think it would be unrealistic for us to expect you to deliver a medicine within an hour of receiving an EPS prescription. I think there needs to be some common sense there, but I would suggest kind of same day, first thing next day, depending upon what time the EPS prescription has been received. Sarah, Kenny, would you agree with that position?
Yeah, that seems, I absolutely agree, Alison. I think, like you say, the deliveries is, you know, like you say, appreciating kind of the logistics of that within an hour. So yeah, I think as soon as possible, but within that kind of 24-hour, you know, like you say, on the day or kind of the next day, would be absolutely fine. I think it's just the recognition that there's, you know, that there is a 5-day treatment window for Paxlovid. So it's just, and we know that sometimes patients won't hit the CMDU on day one. So it's just making sure that we can obviously administer them as soon as possible, but definitely within that 5-day window.
I completely agree. It's about being sensible, pragmatic with it all, and working within the window like we've described. That's the key, isn't it? So as quick as you can would be our advice. Thank you.
Thanks, guys. Sham, was there anything else from you?
No, I'm not going to say anything more.
Your questions are always really good, so please don't apologise. I'm sure everybody else has got the same questions and then you've said them. We have Mohammed.
Sorry, now it's time to go, but just a quick one that came up during the discussions. Alison, Rachel, it's for you. Would you have opening and closing timings for the pharmacies, although the number of hours are similar? The opening and closing times of pharmacies are flexible with them since there have been changes recently.
Yeah, because what we'd do is we'd still look on the EP, we'd put in the postcode and we can see which one's the nearest and we'd see what your opening hours are. And obviously, if it was, I'm just thinking, if it was, say, 10 to 6 or 5:30 for us, then I think that again there's got to be pragmatic that when you're closing, it might be that the next working day is when the patient's advised to pick that up. Then, you know, so we have to also be realistic, don't we, if we're sending a prescription to a pharmacy very close to your end of your day that you might not be able to then get the patient in or the relative to come and collect that. So I suppose that's part of that agreement, isn't it, of understanding when that person's going to come and make those arrangements. And if they don't follow that arrangement 24 hours after that agreement, then they would be sent back to us to follow that up.
Oh, that's fine. Thank you.
Does that answer that question?
Yeah, we got full trust in you. You won't send to us.
Well, and
equally, enough for us that you got the timings, and then of course,
yeah, because obviously we do. Yeah, and we do this sort of within a 24-hour service anyway at the moment. So we know, nobody's open 24 hours these days now anyway. So we know that we advise people when to go to the pharmacy if it is going to be the next working day, and what your opening hours would be. But equally, if there's any issues with any of the prescriptions or any of the information you get in, by all means, I've put my email in the chat as well, and we'd be more than happy, because as Zara said and Alison have said, we're all here wanting to learn and make sure that this is a really good service. So, if you've got any feedback, we gratefully receive it as well.
Brilliant, that's really helpful. Thanks, Rachel. Does anybody else have any questions or comments? Has everybody managed to get some stock? Have you got some packs loaded on the shelves? That'd be good to know. Ready for next week. I know we have had questions from a couple of people just checking around the stock. Don't know if you can give us a yes or give us a thumbs up to let us know you've got the stock. That'd be really helpful.
Well, I'll be coming to Mohammed. He's got them.
Yeah. Oh, good. Can see some thumbs up there. That's good. If you haven't, if you could place it on order so that it comes in tomorrow or Monday, that would be marvellous, please. Because there is a chance, as we said before, you could start to see prescriptions from next week for this service. So if there's no more questions, then I would like to thank you very much for your time and attention this evening. Really appreciate it. I know you probably all had a really long day today, or probably some of you are still having a long day at work. So we do appreciate you joining us this evening. We will share a recording for those who haven't been able to join, and with you guys if there's other people within your pharmacies who would benefit from watching the recording of this session. And I might try and put together just some questions, some FAQs from some of the questions that we've had, because I think that will be really useful for other people to see too. So thanks very much for your attendance and your participation, and best of luck with providing the service. We're here if you need any support. Thanks very much, everybody.
Thank you, everyone.
Thank you. We look forward to working with you all as well.
Thanks, Alison. Thank you. Thanks, Rachel.
Bye.
Thanks, Kenny.
Bye.
Thank you.
Bye.